Neurosurgery Part 3 Radial Nerve Injury Etiology in the axilla by pressure by crutches or fractures and dislocations of the upper end of the humerus or attempts at their reduction. In the spiral groove, fractures of the shaft of the humerus, falling asleep with the arm lying across the edge of a chair or table, Saturday night paralysis, prolonged application of a tourniquet, outstretched arm resting on edge of the table during operations, intramuscular injections of irritant drugs, clinical picture, injury at radius head, injury in spiral groove, and injury in the axilla. Injury at head of radius, motor, paralysis of extensors of the fingers and thumb, finger drop. If wrist and proximal phalanges are supported and extended, middle and distal phalanges can be straightened by the action of interossei and lumbricals. Sensory, no sensory loss. Injury in the spiral groove, motor, paralysis of extensors of the wrist leading to wrist drop, weak grasp, spinator and brachioradialis affection, but supination can still be performed by the biceps. Sensory anesthesia over web space. Injury in the axilla, motor, paralysis of triceps and anconeus. The forearm can only be extended at its own weight. Sensory, back of the arm. Treatment, conservative, nerve repair and tendon transplantation. Conservative, cook-up splint, slight hyperextension of the hand, massage of the forearm and electrical treatment. Nerve repair indications, no recovery within 6 weeks. Prognosis, good because it's purely motor and because it controls coarse unskilled movements. Recovery, expected from 9 to 12 months. Tendon transplantation if nerve repair failed. Pronator teres to extensor carpi radialis for wrist extension. Flexor carpi radialis to extensor digitorum for fingers extension. And palmaris longus to extensor pulsus longus for thumb extension. Circumflex nerve injury, etiology, gunshot wounds, direct blows on shoulder, fractures at the surgical neck of the humerus, dislocations of the shoulder, crutch palsy. Clinical features, deltoid muscle is paralyzed and wasted, acromion becomes prominent and the shoulder becomes flattened. The patient is unable to raise the arm from the side, temporary anesthesia over the posterior fold of the axilla. Treatment, remove the cause of pressure, then do splintage, massage and electric stimulation. Median nerve injury, above the elbow by tourniquet, at the elbow, fractures of the lower end of humerus, dislocations of the elbow joint, gunshots, at wrist, cut wounds, especially by glass due to bursting of bottles or thrusting the hand through a window, carpal tunnel syndrome, compression. Clinical picture, motor, sensory and trophic changes. Trophic changes, severe causalgia and partial injuries, tips of fingers are shrunken and tapering, and cigarette burns are often seen on anaphytic fingers. Sensory, anesthesia over lateral 2/3 of the palm and lateral 3½ fingers. Motor, injury at the elbow leads to paralysis of 2 pronators, losing the forearm pronation, flexor carpi radialis, defective flexion of the wrist on the radial side and impaired radial abduction, palmaris longus, weak hand grasp, especially on the radial side, flexor pulsus longus, the terminal phalanx of the thumb cannot flex, flexor sublimis, outer half of the flexor profundus and lateral lumbrical muscle, leading to pointing index. Injury at the wrist, paralysis of short muscles of the thumb, abductor pulsus brevis, opponens pollicis, and flexor pulsus brevis, leading to wasting of the thenar eminence and it becomes flattened as well. The thumb is extended by the side of the fingers, leading to something called ape-like hand. Opponents cannot raise the thumb forwards at right angles. Abductor pollicis brevis, pen touching test. There's paralysis of the outer 2 lumbricals. Treatment, conservative, splintage in position of function, and operative treatment, division of flexor retinaculum for carpal tunnel syndrome. Ulnar nerve injury, etiology, wounds at the wrist, wounds, fractures, dislocation in the region of the elbow, delayed ulnar neuritis. Delayed ulnar neuritis often follows cubitus valgus deformity due to old injury of the lower end of the humerus. Clinical picture, injury at the wrist, paralysis of medial 2 lumbricals, ulnar claw hand, flexion of the interphalangeal joints, and hyperextension of the metacarpophalangeal joints of the medial 2 fingers, dorsal interossei, leading to wasting with flattening of the hypothenar and interosseous spaces, interosseous muscles leading to inability to abduct and adduct fingers. The patient cannot grip a sheet of paper between extended fingers, cardboard test, adductor pulses, leading to something called Froment's sign. If the patient pinches a piece of paper between the thumb and fingers, the terminal phalanx of the thumb is flexed by the flexor pulsus longus. Sensory, anesthesia over the inner 1½ fingers and ulnar 1/3 of the hand anteriorly only, since the dorsal cutaneous branch of the ulnar arises about 2 inches above the rest. Injury at the elbow. Motor, paralysis of flexor carpi ulnaris, leading to weakness and flexion and flattening of the inner border of the forearm, the inner half of the flexor digitorum profundus, leading to ulnar paradox, less clawing of medial two fingers compared to injury at the wrist, small muscles of the hand with the exception of thinner muscles and the outer two lumbricals, sensory as above, thus dorsal third of the hand, treatment, nerve repair, anterior transposition of the nerve indicated for delayed neuritis due to cubitus valgus deformity and with nerve repair to reduce tension on the suture line or to reduce the gap, nerve transfer, anterior interosseous nerve to ulnar nerve, and in late cases, tendon transfer may be useful. Nerve injuries which may occur under anesthesia, faulty injection or extravasation of nerve irritants as thiopental or propofol, brachial plexus injury when arm is suspended at angle more than 50 degrees at the operating table with external rotation leading to overstretching of the roots, similar effect when allowing the arm to drop off the operating table, arm overextension with head tilted to the opposite side, or plexus compression by shoulder bracelets in Trendelenburg position, ulnar nerve injury when the arms are kept pronated by the side of the patient, nerve compression between the hard edge of the operating table and the medial epicondyle occurs, radial nerve injury, compression between the hard edge of the operating table and the humerus in the spiral groove, or tourniquet injury and faulty intramuscular injections in the arm, sciatic nerve injury, intramuscular injections, or compression in the lateral position of hip surgeries, the common peroneal nerve compressed between operating table and fibula, nerve, tibial nerve compressed in popliteal fossa by knee support in lithotomy position, autonomic nervous system, parasympathetic system originating from cranial outflow passing through oculomotor nerve to pupil leading to pupil constriction, facial nerve to salivary glands, saliva secretion, and vagus to the heart, lungs, alimentary canal, liver, and pancreas, leading to secretory and motor to the alimentary canal and inhibitory to the heart, sacral outflow, course, it passes via the second, third, fourth, and sacral nerves to form pelvic splanchnic nerve, which lies close to the pre-sacral nerve and running upwards to the inferior mesenteric artery at its origin from the aorta, function concerned with emptying, leading to motor pulses to the rectum, bladder, and causing penile erection, sympathetic system, preganglionic fibers, white rami communicants, are the axons of the cells of lateral horns of the gray matter of all thoracic and upper 2 or 3 lumbar segments of the cord, passing from anterior roots to join sympathetic chains. They may form synapses in the nearest ganglion, pass up and down the chain to higher or lower ganglia, or pass through the ganglia to reach ventral ganglia and plexuses. Some preganglionic fibers pass directly to the medulla of the adrenal gland, which represents the synapse and postganglionic fiber. Sciatic nerve injury, etiology, deep wounds of the buttock and thigh, dislocations of the hip, fractures of the pelvis, intramuscular injection of drugs, clinical picture, motor, paralysis of all muscles below the knee, foot drop, if the nerve is damaged near its exit from the pelvis, paralysis of the hamstrings, some degree of knee flexion is possible by the action of sartorius and gracilis muscle, sensory, anesthesia of leg and foot except for the medial aspect of both, supplied by the saphenous nerve, trophic changes common on the sole of the foot and toes, causalgia in the sole, if the lesion is partial, treatment, conservative treatment, suitable support for deformities to prevent foot drop, massage and electrotherapy, nerve repair, a gap can be bridged by flexing the knee and extending the hip, and after operation the knee is kept flexed for 3 weeks, then gently and gradually extended, orthopedic treatment in persistent paralysis, suitable hinged knee splint by orthodesis of the ankle or tendon fixation, great gait improvement occurs. Leg amputation is indicated only for persistent severe pain or extensive trophic ulceration. Differential diagnosis of complete claw hand, combined ulnar and medial nerve injury, Volkmann's ischemic contracture, Dupuytren's contracture, post-burn scar contracture, and Klump's palsy. Common peroneal nerve injury etiology, deep wounds of the thigh, fractures of the upper end of fibula, subcutaneous tenotomy of the biceps tendon, and pressure by strapping bandages and splints with plasters. Clinical picture, sensory anesthesia of the dorsum of the foot and the front with the outer side of the lower 2/3 of the leg, motor, paralysis of the extensor and peroneal muscles in early stages leading to foot drop, and later, on contraction of the opposing muscle, leads to paralytic talipes equinovarus. Sympathectomy indications, vascular conditions, effect, interrupting vasomotor fibers, blood vessels dilatation and improvement of the local circulation. Used in Raynaud's disease, pain is completely relieved, but the attacks of cyanosis still occur. Berger's disease, relieving the pain and promoting healing of ulcers. Relapse after 2 or 3 years are common. Hyperhidrosis, excessive sweating of the hands. Operation, cervicodorsal sympathectomy. That of the feet responds to lumbar sympathectomy. Principles of cervicodorsal sympathectomy. Sympathetic supply of the upper limb derived from second and third thoracic nerves. The preganglionic fibers enter the corresponding ganglia, ascend in the sympathetic trunk to synapse with first thoracic ganglion, a few synapses in the second ganglion, from which postganglionic fibers proceed to the nerve of Kunz and first thoracic nerve. To denervate upper limb, excision of the second and third thoracic ganglia. Sympathetic trunk below the third ganglion is divided together with rami, communicants of the second and third ganglia, and the nerve of Kunz. The stellate ganglion is left intact to avoid Horner syndrome. Approaches: axillary approach, thoracoscopy, anterior approach by transverse incision in the lower part of the neck. Principles of lumbar sympathectomy: preganglionic fibers for the lower limb passing through lower thoracic and upper 2 lumbar nerves to the corresponding ganglia of the sympathetic trunk and descending in the trunk to synapse in the lower lumbar and sacral ganglia. Excision of lumbar chain, preganglionic denervation of the lower limb. Operation: the upper 3 lumbar ganglia are excised. If bilateral sympathectomy is required, preserves the first lumbar ganglion on one side, otherwise failure of ejaculation occurs. Nerve tumors, generalized neurofibromatosis or von Recklinghausen's disease. Pathology: site, widespread affection of the cerebrospinal nerves, nerve roots within the cranial cavity and spinal canal, and nerve fibers in the skin, muscles, and bones. Grossly, affected nerves are diffusely and irregularly thickened with the formation of tumor-like swellings. Histological: proliferation of cells of endoneurium, perineurium, and epineurium are unaffected. Composition: connective tissue fibers arranged in strands, bundles, and whorls. The nuclei are elongated, hyperchromatic, arranged in rows. Palisade appearance: nerve fibers may traverse the substance of the tumor or may be displaced to one side. They aren't the seat of degeneration. No sensory or motor changes are observed. Clinical picture: type of the patient, often familial and begins in adolescence. Symptoms: commonly preceded with localized areas of pigmentation in the skin, café au lait patches, slowly growing swellings. In malignant change, pain, anesthesia, and paralysis of the area affected, with progressive increase in the size of the lesion. Signs: multiple variable size fusiform tumors all over the body, with long diameter in axis of the affected nerve, lying in relation to the plexuses at the root of the limbs, firm or soft in consistency, mobile in a lateral direction, but not in the line of the nerve. The affected nerves may or may not be palpably thickened but painless. Treatment: excision of all tumors is impossible. Indication for operation: very large tumors, painful tumors, and tumors producing pressure symptoms. The tumors should be completely resected. Cutaneous neurofibromatosis or molluscum fibrosum. Pathology: multiple soft fibrous swellings arise in connection with the terminal filaments of the cutaneous nerves. Size: variable from pin's head to lemon size or larger. Shape: sessile or pedunculated. Site: over the scalp, limbs, abdomen, and back. Palms of the hand and soles of the feet. Scape: in most cases, skin is the seat of pigmented areas, café au lait patches, or frank melanoma. Treatment: excision of the large and unsightly tumors. Plexiform neurofibroma. Pathology: diffuse fibromatous thickening of the branches of a nerve, forming beaded swelling under the skin. Site: subcutaneous tissue of head and neck, large nerves of the limbs, and autonomic plexuses of the abdomen. Clinically, the overlying skin is often pigmented and thickened and may hang down in pendulous folds, something called pachydermatocele. More than half of the cases has manifestation of generalized neurofibromatosis. Elephantiasis neuromatosa, related to and may coexist with cutaneous neurofibromatosis. Type of the patient: childhood. Site: affecting one of the extremities, especially the lower. Clinically, affected part gradually increases in size. Skin and subcutaneous tissue are greatly thickened. Variable number of tumors may be present and the skin may be pigmented and hairy. Acoustic neuroma, incidence rarely associated with neurofibromatosis, has familial incidence, dominant trait, associated with tumors of the dura and choroid plexus. Neurofibrosarcoma, origin de novo in an apparently normal nerve or by malignant degeneration in neurofibroma. Shape: spindle cell or myxosarcomatous character. Clinically, painful, rapidly growing tumor which invades surrounding tissues, leading to anesthesia, paralysis, and distant metastasis. Treatment: in localized tumors, wide excision, and in extensive tumors and post-operative recurrences, amputation. Neurofibromatosis, definition, proliferative condition of the endoneurium of nerves associated with tumor formation and sometimes with pigmentation of the skin, includes several varieties, either singly or combination. Solitary neurofibroma, incidence between 20 and 50 years, usually affecting nerves of the upper limb but may occur in spine, mediastinum or viscera. Clinical picture, small elongated firm tender swelling, very liable to cystic degeneration. Treatment, complete excision. Ganglioneuroma, pathology, nature, benign tumor, origin, sympathetic trunks or adrenal medulla, histologically, uni or multipolar ganglion cells scattered among non-medullated nerve fibers, grossly, well encapsulated, size, variable from a pea to a large melon. Clinical picture, occurs in childhood, symptoms, rounded or lobulated soft swelling which attracts attention by its size or pressure effects. Treatment, inoculation, easy since it's well encapsulated. Neuroblastoma, pathology, highly malignant tumor, origin, sympathetic chain or the adrenal medulla, histologically composed of small round cells with hyperchromatic nuclei arranged diffusely in rosettes. Ganglion cells and nerve fibrils are often present. Grossly, reddish-purple soft swelling liable to hemorrhage and degeneration which grows rapidly. Size, reaching large size and metastasized by blood and lymph vessels. Site, most common in the abdomen and neck. Clinical picture, type of the patient, childhood, early childhood specifically. Symptoms, large retroperitoneal mass which soon metastasize. Treatment, the tumor is highly radiosensitive but metastases are so early with widespread that the prognosis is not favorable. Surgery of the spine and spinal cord, spina bifida. Definition, split spine. Prevention, folic acid administration during pregnancy. Site, mostly lumbar spine. Types, spina bifida occulta, meningeocele, meningomyelocele, syringomyelocele, and myelocele. Spina bifida occulta, 10% of population. Defect, complete development except for a bifid spine. Skin is connected to meninges by fibrous band, something called membrana renions. Clinically, lipomatous swelling, skin dimple, or tuft of hair. Complications in a minority of cases at puberty, incontinence of urine, or lower limb motor deficits, because spine elongates faster than the spinal cord, leading to membrana reunions, causes cord traction. Investigations, plain X-ray, deficient laminae of the spine. Meningeocele, bulging of meninges only through the spinal defect. Meningomyelocele, bulging of meninges and neural tissue, normally spinal cord or coda equina within the thigh. Dark shadows on transillumination. Incidence, commonest type of spina bifida, associated with Arnold-Chiari malformation, fourth ventricle, lie at a level below the foramen magnum, leading to obstruction of the CSF flow and hydrocephalus. Prognosis, if untreated, 75% die within the first year of life. Syringomyelocele, rare. Definition, dilatation of the central canal. Myelocele, complete spina bifida, defect, failure of fusion of the neural tube. Clinically, open spinal plate, dribbling of the CSF incompatible with life. Spondylolisthesis, definition, disorder in which there is fourth or fifth lumbar vertebral defect, its body slips forwards on the sacrum. Clinical picture may be clinically obvious if there is a step in the lumbosacral spine. Treatment, in early cases, physiotherapy, rest and spinal support. In gross cases, spinal fusion by bone grafting with sometimes removal of the prolapsed intervertebral disc. Clinical picture of the spina bifida, antenatal screening, ultrasound, high levels of alpha-fetoprotein in amniotic fluid. Spina bifida occulta, usually asymptomatic, accidental finding in X-rays. Lipoma, skin dimple or tuft of hair over the bifid spine, rarely urinary incontinence starting at adolescence. Meningeocele, no neurological manifestations, cystic translucent swelling with expansible impulse on cuff, the swelling is compressible. Meningomyelocele and syringomyelocele, paraplegia, wasting, or contractures with sensory loss, marked trophic changes, particularly perforating foot ulcers, commonly associated with hydrocephalus. Treatment, spina bifida occulta, no treatment required if membrana reunions produces incontinence, surgical division. In other forms, surgery early as possible. Tile operation covers the defect by flaps from the lumbar fascia. Excision is done only in pure meningeocele and not in types which contain nerve tissue. Ventriculoperitoneal or atrial shunt for hydrocephalus. The order of frequency of spina bifida types, spina bifida occulta, usually asymptomatic, meningomyelocele, neurological manifestations plus lumbar swelling, meningeocele, lumbar swelling. Spina bifida may present as isolated anomaly or associated with other anomalies, vacterel, V-A-C-T-E-R-L, V vertebral, A anorectal, C cardiac, T tracheal, E esophageal, R renal, and L lumbar. Fractures and dislocations of vertebrae may produce spinal cord and nerve root injuries Site mostly at the junction of the mobile and rigid parts of lower cervical and dorsolumbar regions. Types: we have wedge compression fracture, fracture dislocation, and comminuted or burst fracture. Wedge compression, trauma, hyperflexion, body, front compression, ligaments and facets. Posterior spinal ligaments are intact, stable. Spinal cord or caudal damage, undamaged. Fracture dislocation, trauma, hyperflexion accompanied by rotation. Body, forward dislocation of the vertebra with articular processes breaks. Ligaments and facets. Posterior ligaments are also torn, unstable. Spinal cord or caudal damage, commonly damaged. Comminuted or burst fracture, trauma, vertical compression. Body, comminuted. Ligaments and facets intact, stable. Spinal cord or caudal damage, sometimes damaged. Pure dislocation occur in cervical spine only because its articular processes are rather horizontal, similar consequences to fracture dislocation. Avulsion fractures of transverse and spinous processes, not accompanied by neurological injury, and no treatment is required. Dislocations and fracture dislocations of atlas and axis vertebrae are serious because it leads to cord transaction above the level of the respiratory muscles innervation, which is fatal. Hangman's fracture, atlas dislocation with or without odontoid process fracture. According to the stability, we have stable and unstable fractures. Unstable fractures, fracture dislocation, and pure dislocation. Stable fractures, wedge compression, comminuted, and avulsion fractures of transverse and spinous processes. Neurological injury, pathogenesis, injury of spinal cord, nerve roots, or both. Effect, paraplegia or quadriplegia. Prognosis depends on level and nature of the fracture. Level of the lesion, injuries at the level of T12 and L1 vertebrae, combined cord and root damage, transaction of sacral cord, and paralysis of muscles controlling the hip. Injury at the level of D10 isolates the entire lumbar and sacral cord, permanent paralysis of the lower limbs and viscera. In cervical spine fractures, level of cord injury corresponds to the level of bone injury. High cervical cord transaction is fatal because all respiratory muscles are paralyzed. Nature of lesion, spinal cord concussion, like cerebral and nerve concussion, neurapraxia. Recovery, spinal cord damage by contusion or laceration. Transaction, don't recover. Types, complete transaction or hemisection, Brown-Sequard syndrome, coda equine injury. Stages of cord transaction, shock stage and stage of reflex activity. Shock stage, timing, early stage, presentation, complete flaccid paralysis, below the level of injury, loss of tendon reflexes and atonic distended bladder, duration, lasting for a few days. During this stage, cord transaction is suspected with the following: complete loss of all forms of sensation below level of the lesion. If sensory loss and paralysis rise after injury, ascending edema. Damaged cord, which hasn't recovered in 48 hours, will never recover. A very sure sign of cord transaction is the appearance of a mass reflex at 3 to 6 weeks and presence of anal and penile reflexes in the absence of sensation in the legs. Stage of reflex activity, presentation, reflex function below level of transaction, recovers, leads to spastic paralysis and reflex emptying of the bladder. Clinical picture, spinal injury is suspected after any major trauma. Cervical collar is applied and immobilized of the head. Search for another injuries of the skull, chest, abdomen, or limbs. Local signs, the patient is gently rolled onto his side in one piece. Slight kyphosis may be visible or felt. Local tenderness over the spinous process. No gap is palpable between the spinous processes in stable fracture. In unstable fracture, separation of the spinous processes may be evident. No attempt to test back movements because paraplegia may occur. Neurological assessment for sensations, motor power, and reflexes. The spinal cord ends at the lower border of the first lumbar vertebra. Fractures below this level leads to root lesions of the coda equina. The first sacral cord segment is opposite to the dorsolumbar junction. The first lumbar cord segment in adult is at the level of D10 vertebra. In cervical spine, cord segments correspond to the level of the vertebrae. In concussion, joint position which ascends in the posterior column is preserved. The stability of spine fracture depends on the integrity of posterior ligaments. Always suspect spine fractures in victims of major trauma. Investigations, plain X-ray, views, anteroposterior, lateral views, special views through the open mouth. Diagnose fractures and dislocations of the atlas vertebra. Cervical spine films should show all 7 cervical vertebrae and T1. CT scanning is the most sensitive. MRI best to reveal spinal cord injuries. Treatment, initial management. Treat first-line threatening problems as airway obstruction, breathing, bleeding. Deserve priority in the management. Prevent spine movement by applying cervical collar to immobilize the head during transport and examination. The trauma victim is moved onto the stretcher all in one piece, never lifted by the shoulders and the thighs. In hospital, the patient is nursed on a bed with fracture boards. Treat shock. Stable fractures, wedge compression fracture, extension exercises for the back muscles. Prognosis: within a month, he's allowed and can resume work in 3 months with painless, mobile, and powerful back. The compressed vertebra remains wedge-shaped. Comminuted fracture: apply plaster jacket in the neutral position, straight spine for 3 months, and patient can walk with it. Regular spine exercises after applying the plaster jacket. Prognosis: severe pain and delayed healing. Avulsion fractures of the transverse or spinous process. Rest and analgesics. And for unstable fractures, traction and hard cervical collar. Pott's disease of the spine. Paraplegia in Pott's disease, incidence 10% of cases. The level of cord affection is usually in upper dorsal spine, the narrowest part of the spinal canal. Etiology: compression on the spinal cord by cold abscess, angulation of the spine, thrombosis of the anterior spinal artery. Clinical picture of Pott's disease of the spine. Symptoms: general, night fever, sweat, loss of weight, appetite. Local pain which increases on movement, may be referred along the nerves of the abdomen. Signs: limitation of movements in all directions. This is the most important sign. Child is unable to pick a coin from the ground with knees straight. He has to bend his knees, and on rising he climbs on himself. In cervical region, patient supports his head with his hand and rotates as a whole. Angular kyphosis, if thoracic region is affected. In cervical and lumbar regions, they are masked by normal lordosis, just obliterated, and spine looks straight. Cold abscess, investigations. Plain X-ray, 2 or more vertebrae are affected. Intervertebral disc space is narrowed and completely lost later. Adjacent surfaces of the vertebrae are irregular. Absence of new bone formation, this is characteristic. Paravertebral abscess shadow. CT scan, vertebral bodies may be collapsed with areas of bone destruction. Treatment: conservative treatment, mainly anti-tuberculous medications for 9 months. Rest and good nutrition. Spine support by plaster cast for short periods, then by spine brace after improvement. Periodic clinical, hematological, and radiographic assessment. Prognosis: most cases are cured even with early paraplegia. Surgery indications: early Pott's paraplegia with no sign of recovery after 3 to 4 weeks of conservative treatment, or paraplegia getting worse in spite of conservative treatment. Aim to decompression of the spinal cord. And this concludes our part for the neurosurgery and the whole of the neurosurgery.